Good evening, everyone. My name is Lindsay and I am the Client and Lab Services Manager here at Examen. And it is my pleasure to welcome you all to the second webinar in our 2023 Male Fertility Series. If you're new to our webinar series, the webinars take place on a monthly basis and we are joined by an expert in their field of fertility treatment or therapies. The event is free and open to everyone, and we have a wide range of participants attending. The views presented in these webinars are the views of our speakers and not necessarily of our company Examen. You're very welcome in joining with us this evening, so please let me introduce you to our speakers. This month, we're delighted to have joining us Dr. Alison Campbell. Dr. Campbell started her career as an embryologist in Liverpool and has led the embryology team in Care Fertility for over 25 years since its inception in 1997. Her knowledge, experience, and leadership skills have made her an international key opinion leader in much demand for lectures and seminars. So we are delighted she has taken the time tonight to be with us. Our chair, Professor Sheena Lewis, is the founder and CEO of Examen. She is widely published and has been an office bearer of UK and European learner societies for the past 20 years. Before I hand it over to Professor Lewis, I will just run through a few quick housekeeping. We will start with a welcome and introduction from Professor Lewis. Then at approximately 6:15 to 6:45, we will have our guest speaker presentation, followed by a Q&A session with our speaker and Professor Lewis from 6:45 to 7. Please do pose questions throughout the talks using the Q&A panel, not the chat function. You will also have the opportunity to rate questions, and Professor Lewis will then chair these during the Q&A session. If you experience any technical issues, please use the chat function and we will do our best to help you. Attendees will be muted throughout and videos enabled for our speakers only. All the events in the series are recorded and made available on the events page of examenlab.com following each session, so you can watch any events you may have missed. Please allow up to 24 hours for the recording to be available. 1 CPD point will be awarded for attendees for the 1-hour event, and a certificate will be circulated within 24 hours. At the end of the session, you will be invited to rate the event. Please do so, and we welcome your feedback on tonight's webinar, as well as suggestions for future sessions. So without further ado, I will now hand over to our chair, Professor Lewis, to start the session. Sheena?
Yep, I'm here. Good evening, everyone. It's a pleasure to be with you this evening, and I'm just getting my slides up here. I'm really glad that you've all been able to join with us. We have a super speaker this evening, someone who hasn't shied from controversy throughout her career. Being in the fertility sector is a very controversial one, and there are lots of people with lots of different opinions. And it'll be really good for us to talk about add-ons tonight, because this is something which some people are very keen on and other people are not so keen on. And it'll be really good to have someone who has the inside knowledge from the HFEA and can talk us through what opinions are and what the benefits are to patients. Now, as you know, all of you have been on our webinars in the past. The purpose of the webinars is to raise awareness of male infertility. Now, we're spreading it a little bit more tonight to include women, but usually we are talking mostly about men. And what we want to do through these webinars is to provide men with knowledge and also to let them know a little bit more about the types of advanced testing which are available for them. And of course, our purpose is to help the men who want to become dads. We have throughout my career in Queen's and the career of the business over the last decade, been involved in many research projects in order to demonstrate that couple care can improve live birth rates and to demonstrate that optimizing sperm health prior to treatment can improve fertility outcomes. And our really big ambition is to help 1 million men along their way. Now, understanding the exact test, which is the fertility test, which we offer, is very, very simple. We used to have a more complicated report, but now we've simplified it because that's what both clinicians and couples want. What we can tell you is that fertile men set a very high threshold for their sperm DNA quality. And looking at fertile men and fertile men's sperm, we find that up to about 90% of those men have got really good quality sperm DNA. And that's because sperm DNA is the absolute essence of sperm. It has DNA and it has a tail. The tail to allow it to swim on that marathon journey to reach the egg. And then the only other thing that it needs is the DNA, which will combine with that of the oocyte and form an embryo. If you get high DNA damage, well, it leads to increased risk of infertility, increased risk of miscarriage, and lower success rates by IVF. Now, all the results that we generate are generated to ISO 13485 certification, and we are undergoing the ISO 15189, and the week before last, we were recommended for this. So this is the absolute top quality standard that we have within our business. The evidence base for our test is over 25 years of academic, non-commercial, non-biased research. And as you can see here, we've looked at prescription drugs, we've looked at cannabinoids, and I saw a big paper last week looking at cannabis again, not the cannabis that you smoke, but the cannabis that we actually have within our own bodies. We've looked at motility enhancers, we've looked at diseases, we've looked at miscarriage, and we've looked at how DNA could be used as a biomarker for those 30% of couples who have unexplained infertility. Now, there are a couple of different DNA tests around, but we would say that ours is the most accurate in terms of sensitivity, specificity, and predictive power. It's the only test that reports both the proportions of good and poor quality sperm and compares them to sperm from fertile men. And it's the only test that gives you clinical thresholds for infertility, miscarriage, and IVF live births. The other big advantage about using it in your clinic is that it requires just a small number of sperm, making it reliable for men who've got low sperm counts, for surgically retrieved sperm, or if you just want one sample of semen and then you can use it for a number of different tests. And we have a very fast turnaround time. We have ongoing research both into men and into their sperm. We're looking at the effects of varicocele, which is a very, very common problem. 40% of men with primary infertility have varicoceles, and these can have an impact on both their semen and also on their fertility outcomes after treatment. We're looking at infection, we're looking at microbiomes, we're looking at sperm sorting techniques, and we're also looking at sperm DNA as an indicator of male health, not just fertility. Now, we're delighted that over the last couple of years, there's been a huge step forward in terms of the numbers of learned societies who have now taken on DNA testing as either routine or recommended tests in addition to a semen analysis. And even the WHO, a couple of years ago, they came out with the latest manual, and they said, look, we cannot find out everything that's wrong with a man's semen from a semen analysis, but let's do extended examinations, and sperm DNA fragmentation was in that. So that is a world recommendation for us, and we're delighted to see that. Now, we come to tonight's speaker, and it really is a pleasure for me to introduce Dr. Alison Campbell to you. Alison is a scientist. She's a diplomat of the Royal College of Pathologists. She did her PhD in embryo selection a number of years ago, and her career has been based ever since in a very focused way on improving the embryology lab, training the embryologists, advancing the lab techniques, leading 8 embryology teams with 60+ staff. And I'm sure that's completely out of date. It's from the web, but even this evening, Alison was telling me that they've set up clinics in Spain and the first one in America. So no doubt that is more people that she has to manage, which she manages to do herself with great verve. And I must say, she never neglects a side which I'm particularly interested in, and that is the research aspect of things, because when we have fertility conferences, the national conferences, when we have international European conferences, there are always numerous abstracts from her embryology team. As I said earlier, Alison doesn't shy from controversy. She has been involved in setting up an egg bank, in time-lapse microscopy, which I think she's going to speak about a little bit tonight, in embryo quality mapping, And now she's going to turn our attention to add-ons, another controversial area. So it is my pleasure, Alison, to hand over the floor to you to tell us if you think add-ons are useful.
Thank you very much, Sheena. I love hearing you speak about sperm. You just bring it all to life, and it's a pleasure to hear you speak about sperm. So I'll just find my slides. Yeah, I'll just update you. Yes, we now have 19 labs across the care group, so we are growing fast. A really big team, so it's not down to just me. We've got a great team of lab managers, embryologists, and we've got a scientific director as well. So yeah, it's going very well. So tonight I'm going to talk to you about add-ons and whether or not they're worthwhile. So just a little bit about what we mean by add-on, because I think different people have different perceptions, and why it's a really important topic. I don't want to be too controversial, but yeah, we need to talk about it. It's an important topic. A little bit about the position of our regulator, the HFEA, and our professional bodies and societies in the UK and beyond. And I think it's really important always to bring it back to the patients. What does it mean for them, and why is it important that we talk about add-ons for them and with them? And I just wanted to, I've been thinking about the challenges that we face as professionals, and also how patients face challenges when we're talking about add-ons, because it's really difficult to navigate the literature and the guidelines. It's a really rapidly moving field, as we know, and it's a challenge for everybody when we're looking at add-ons. I wanted to mention the outcome measures, because there are so many. It's not just about a baby. I mean, of course, that is the most important thing, but it's not the only thing that matters. So we'll be talking about whether there is a better way, and I'm looking forward very much to the discussion at the end. So what is an add-on? Well, I prefer the term adjuvant. So it's a supplement, it's an adjuvant. It's something that we can add on to a conventional treatment for our fertility patients. Add-ons, they claim very often to be effective at improving outcomes, and we'll look at the different outcomes that some of them claim to be improving and whether or not that's a valid claim or not. And generally speaking, and I think probably the reason why add-ons get so much attention and controversy is because they are likely to involve additional cost. So some years ago, a consensus statement was published on the responsible use of treatment add-ons in fertility services. And that's really important. And these were the bodies involved in that consensus statement. And since then, there's been a lot of discussion, a lot of debate. And so we're going to cover some of that discussion through the next 20 minutes or so. So in terms of the UK and the HFEA, our regulator, because I'm conscious that we have a wide audience, we may have international people listening. And of course, the HFEA and the UK, for that matter, are very much seen as leading the way when it comes to regulation in our field, and often in standards in our field, which is a great place to be. So they've had this challenging job of trying to classify add-ons. And the way the HFEA approached it in terms of traffic lights were, they asked the question, are there high quality randomized control trials showing that these add-ons are effective at improving the chances of having a baby for most fertility patients? So it's it's a very broad statement. And based on that statement, then they go through and they classified with a team of experts each of the add-ons and whether they are red. No, there is no evidence that they're effective at improving chances. And when I say evidence, in terms of high quality randomized controlled trials, or there's conflicting evidence. So these randomized controlled trials or different studies have been published, so some showing benefits, others showing no benefits, or green, it's fine. Plenty of randomized controlled trials of a very high quality showing add-ons are effective for most fertility patients wanting to have a baby. So it's important to say that the HFEA do specify that for specific patient groups, there may be reasons for the use of a treatment add-on other than improving the chance of having a baby. So I'll come back to that point, but this may be reducing the miscarriage rate, for example. So then they go on to say on their website that it may be appropriate for a patient to be offered a treatment add-on as part of their treatment. And we need to remember that these traffic lights were developed for the patient because there is a lot of information out there, and the HFEA felt, supported by this consensus statement by all of those professional bodies and important patient support groups, that patients need this important information to help them make a decision when they're approaching fertility treatment. So add-ons can be, not just in terms of the HFEA, but across the world, they can be diagnostic interventions. Sometimes these are offered at an extra cost for particular patients. They can be genetic tests, they could be surgical, medical, medications, equipment, different equipment uses in the laboratory or outside of the lab. They can be lab techniques, they can be alternative therapies. So they can be many, many things. And they are understandably a very hot topic and a moving feast. So not just the HFEA currently, but ESHRE are also looking at add-ons, and they're a step ahead with a proposed guideline, a draft guideline, which is now, it has been out to the stakeholder review, it's now closed, but they identified 27 add-ons right across the board, for some very novel, some very well established, and they have tried to pull the literature together with a group of experts and make some recommendations on whether they should be used or not, and whether or not they're safe. And similarly, the HFEA have the Scientific and Clinical Advances Advisory Committee, the SCAC, it's better known as, and this is a subcommittee of the authority who regularly review the evidence. And I know Sheena was very much involved in that committee, and I've recently joined that committee with the authority. So I've got first-hand impression of how that's going, and there is certainly a lot of discussion, and these add-ons are being assessed based on their evidence, and also the traffic light system, whether or not it's appropriate or needs further development. So many examples, and I've just selected a few for this figure. Some of them are not on the HFEA's list, but and Sheena may disagree, but with some of these, well, they're all adjuvants, so they may not be add-ons and they may not have a traffic light, but all of these different elements, they can be added to a patient's treatment based on their indication, based on if they may benefit that patient. So we've got so many here, you can have a look there: time-lapse systems, sperm testing, endometrial assays, there's hyaluronan enhanced transfer medium, intravenous immunoglobulins, assisted hatching, that one's been around a long time. So I've put here the traffic light colours that the HFEA have given them. So red for assisted hatching. So red, again, meaning there is no robust evidence that this makes a benefit for all patients having fertility treatment in terms of their chance of having a baby. We've got artificial egg activation there with an amber. So there's mixed opinion. There may be some evidence there. It may be too soon to say. So it is a minefield. And when we put ourselves in the patient's shoes, whilst they have these traffic lights, there's still a lot of information for them to take in. And it must be very difficult for them in the consultation room if they're being offered a treatment adjuvant, an add-on, that has been given a red light or even an amber light by the HFEA. So are they useful? It's the critical question. Well, I think we need to consider, are they useful for what? So these different adjuvants, these add-ons can be used for improving embryo selection, potentially, for live birth, potentially, reducing the miscarriage rate, for choosing the best sperm, for reducing the time to pregnancy. So there are lots of different things that add-ons could be used for. But we need to remember that when we're looking at the HFEA's traffic light system the question is, are there high quality randomized controlled trials to show that they're effective for most patients? And that's really difficult. And I just wanted to say, generally in our field, whilst we have at Care Fertility 19 labs and 150 scientists, it's still really difficult to conduct randomized controlled trials. They take a lot of resource, a lot of funds, time, and by the time they've completed, they're often out of date. We've seen so many examples over the years where they've taken so long to get going, and before you know it, there's a new technology and it's old news, and a lot of time and effort's been wasted. So it is difficult for clinics to perform randomized controlled trials. So I think we do need to think about whether there are other types of data and evidence that could be useful to help inform our decisions when we're deciding as clinics which add-ons to offer to our patients, and also for the patients to help them make the choice as to what may benefit them individually. It's also really important, I think, and my colleague is always saying this, and I think it's very valid. We need to make sure we're not doing any harm. As long as these add-ons are safe and we're providing patients with as much information as is possible, then we should be at liberty to offer them, and they can make an informed choice as to whether or not the treatments, the add-ons, would benefit them. So we'll come back to that again. But the list keeps growing. There are so many add-ons, and this list is just from our review at Care Fertility. So we have a section of laboratory-based embryology, adjuvant, diagnostic, and therapeutic treatments. And we also have a list of clinical related ones. We're not offering all of these, but we've just gone through the process of reviewing them, just like the HFEA does, just like ESHRE does, because it's nice also to do it in your own, within your own team, with your own experience, your own data, and to review the literature if you have the time and the resource to do that. So the challenges when we're looking at all of this data and all of these add-ons are that we get these conflicting reports of efficacy, and it's a nightmare to navigate. And when we identify the randomized controlled trials or the publications that are relevant to each particular add-on, we find heterogeneity in practices and also in the application. So we've said that randomized controlled trials are difficult to conduct. So we're faced with so many challenges around the area of add-ons. And I think that randomized controlled trials are fantastic, of course, they're brilliant. But there are other ways to get data, to get evidence together, such as just big data. If we've got multiple clinics compiling, pooling data and analysing, then this has to be taken seriously. And case series, if a clinic introduces a new add-on for a long period of time and they're accumulating a lot of data, let's look at how that data looks compared to the treatments prior to that, providing there weren't any substantial changes. And matched controls, this is another thing that we can do, is to match different patients who've had the adjuvant, the add-on, and those that have not, and see if there's a difference there. And I think we maybe talk about this later as well, Sheena, but should clinics have to demonstrate that add-ons that they're offering work in their own hands? Because I think that's the icing on the cake. If you implement an add-on, let's use a laboratory add-on, for example. So we introduce a culture medium, which is enhanced with cytokines, GM-CSF, which does exist. Should we demonstrate that that works in our culture system, with our oil, with our dishes, with our CO2 concentrations, or we just take it off the shelf and that's it, we offer it? We need to make sure that we're confident and competent in offering these add-ons and they work in our own hands, in our own systems. And then do we need to consider other outcome measures? So cumulative pregnancy rate, really important. We don't hear enough about that. And miscarriage rate. Patients who've come to us and they've had multiple miscarriages, they don't want to face any more miscarriages. So anything we can do to reduce the chance of the miscarriage. Every patient needs the minimum rate of miscarriage. We don't want miscarriages. We want babies. So if we can take steps and offer add-ons to reduce miscarriage rate, then we should be doing that. And of course, time to pregnancy, something that we hear talked about very much, particularly with PGTA. So PGTA and other embryo selection methods like time-lapse monitoring algorithms, they're not going to change the embryo, or we believe they're not going to change the embryo. But if they can help us choose the best embryo first time or sooner, then the time to pregnancy is shorter. And that's very important for patients. And that brings cost efficiencies rather than futile consecutive frozen embryo transfers. Let's choose the best one first time. So the most important message, I think, of my presentation really is that patients need transparent information. They need informed consent on all of these add-ons, and they need to be indicated for them. We don't want to just generically offer all patients all add-ons. That would be silly. It would waste a lot of time. We'd be charging patients for things they didn't need. But not jumped ahead. So that's an important message, that if they're indicated, then I believe we should be offering them. We should be competent in offering them. So I'll just move on to the ESHRE draft guideline briefly. So here we have 27 different elements and add-ons that ESHRE team, the expert group, have analysed. They've looked at the literature and they've gone through really methodically, and it's only a draft, so it's not out and published yet. So it's been gone back up to stakeholder review, so there may be some changes. But they've gone through the literature and they've mapped out the evidence, and they've concluded whether or not they believe these add-ons should be recommended, and whether or not there are particular patient groups that should be recommended these treatments. And they've also gone on to say whether or not there's evidence that they're safe or not. So best for our patients is the access to effective, safe add-ons in their treatment and transparent information, as I said. So it can be diagnostic. So these add-ons, I think, are important. We may not call them add-ons, but they are adjuvant therapies. They're diagnostic tests. And we need to ask, will they inform the treatment management? And will they add benefit for our individual patients to help us give them the best optimized treatment, rather than take a lot of false turns and accumulate information through a series of IVF treatments? And therapeutic, is it going to improve my chance of success? So the key questions really for the patients from their perspective: where's the evidence? Is it safe? Is it proven? And what's it going to cost? And then they can make the informed decision. They can balance the cost benefit, and they can understand better. Providing we make this information as transparent and as clear as possible, it will help them make the best choices. So just to use an example, because it always brings things to life, I've chosen time-lapse imaging as an example, sort of a case study, just to go through briefly with you. So the HFEA gives this an amber light currently, and the ESHRE draft guideline says, yes, they recommend it for incubation. It's an incubator, time-lapse imaging, tick, but not for embryo selection with software. They didn't feel there was sufficient evidence to show that that is beneficial. The difficulty with time-lapse imaging studies, in my opinion, is that they are particularly heterogeneous and there's a risk of bias. It's a relatively new technology. It's been out for 10 years, probably in routine clinical use, but everybody has a different way of approaching it. We've got different culture media. We've got different methods of annotation. There are guidelines. There's a best practice guideline for annotation of time-lapse videos. So this is when the embryologist sits and watches the videos and records what's happening and when. But the randomized controlled trials are very heterogeneous. Some of them have used algorithms. They've really not used the same algorithm. So there are different morphokinetic variables going into these different algorithms. And some people have just tested them out as an incubator. So the ESHRE guideline says, yes, it's okay as an incubator, but there's not enough evidence to show that embryo selection software is effective. So, but does it work? Well, I think it works. I think it's an amazing technology. Sheena said, I've done my PhD using time-lapse imaging, and it offers so many benefits for patients. So this uninterrupted culture, we get these videos which we can analyze. I know, and we've published, that morphogenetic models can predict birth and can predict ploidy. So not as binary, not as sure as PGTA in terms of ploidy, but we can get a prediction of ploidy with quite a high confidence just from the morphogenetics, just from the patterns of embryo development. So that's important, I think. So patients who don't want PGT, or in countries that can't have PGT, they don't have the technology, or they're not permitted to perform embryo biopsy and testing, then this tool could really help them. So we get much more information than we would from morphological assessment. And it's better for setting patient expectations. We can talk to them about what we've seen in the laboratory. We did a big survey from about 1,000 patients. And the feedback was, we just love, we understand what's happening in the lab much more than we did before because of time lapse. And we like the way that the embryos aren't disturbed. And I'm going to just explain a little bit more about a more reliable fertilization assessment. So hopefully you can see that there are many benefits to time-lapse imaging, and whether or not there's an improved chance of live birth for most patients, for all patients, like we would like to be able to say with the traffic light system, it's too soon to say. We don't have those large randomized controlled trials, but there are multiple other benefits, which I believe that patients need to be offered so they can make their own decision. So this was a publication from our group last year, 2021, by Amy Barry and colleagues. So we analysed about nearly 80,000 embryos, and we looked at the time that the pronuclei were visible. And we tried to extrapolate to our standard culture system and looking at the Istanbul consensus guideline. So when we check for fertilization in a standard incubator, like is commonplace across the world, and if we're following the Istanbul consensus guidelines, which states that we should check for fertilization for the pronuclei at 17 hours post-insemination, plus or minus 1 hour, we will be missing pronuclei. We will be scoring embryos as unfertilized. So we've proposed to shift the window of observation of fertilization to 16 to 16.5 hours. So it's earlier and it's a shorter window of opportunity. But even then, with standard incubation, we're only going to be able to observe just over 98% of pronuclei. So it's a lot, but we're not going to be able to see them all, because some will either have not appeared yet, but more likely they will have faded. So from this really large study, had we not had time-lapse imaging to assess fertilization, we would have scored 300 embryos which went on to be transferred and result in a live birth. We would have scored them as unfertilized. So we are doing our patients a disservice if we're not offering add-ons that can improve the chances, not just of a live birth, but of maximizing the number of embryos that they have to aid our selection and to freeze for future attempts. And again, on the topic of time-lapse imaging, another example from our group. So we made an algorithm to predict live birth, and this was based on over 6,000 blastocysts that were transferred where we knew the live birth outcome. So the blue bars, here we are, the blue bars are the predictions. So from this big data set of transferred blastocysts, we developed an algorithm, and you can see that the score from 1 to 10, the live birth prediction, if the score was 1, so it's got quite a very poor morphokinetic profile, it's not developing, just as we would like, then the chance of a live birth was less than 5%. But going up to a high score of 10, really beautiful morphokinetics, the algorithm does its magic and we get 10 points, then we're getting an over 45% chance of live birth. So we then introduced this morphokinetic algorithm to predict live birth prospectively to our patients. This was the 6th iteration of our algorithms. And we looked at the actual implantation data. So this is 1,500 embryos transferred, clinical pregnancy rates. We don't have live birth data yet, but you can see that the model is performing perfectly. So the yellow bars showing the actual clinical pregnancy rate based on those morphokinetic scores. So it is reliably predicting the chance of live birth. So we can give our patients this information. We can help them make informed choices. If they've got an embryo with a score of 1, we can talk to them about the chance. And for some patients, a chance of 5% live birth is a chance and they want to take it. For other patients, they'll say, no, I don't want that embryo cryopreserving. I'd rather not have that false hope. I'd rather have a fresh cycle and invest my money that way rather than storage fees and an FET. So this is a really important point, I think, that we need to make sure that patients are furnished with this information to help them make the best decision for them. So back to the ESHRE guideline. So there are 27 and only 3 of the add-ons on the ESHRE guideline were generally recommended. So there are some that are recommended for particular indications, but only 3 were generally recommended. And even then, they had some provisos. So there was a microfluidics for sperm preparation. They said there's no harm in it. It's safe, they believe. There's some positive research out there, but more research is required. Time-lapse imaging we've mentioned, and the hyaluron enhanced transfer medium, they said there's sufficient evidence for that to be recommended, and particularly for single embryo transfer. And I thought, because we're here at Examen, we need to talk a little bit about andrology. Not that they're necessarily considered add-ons in the UK, in the HFEA's website, but from the ESHRE draft guideline, these andrology-related add-ons were cited, and they said that they were not generally recommended, but were considered safe. So the hyaluronan binding assay and the physiological ICSI, MAX, IMSI, ICSI for non-male factor, DNA fragmentation and oxidative stress testing. So the ESHRE group decided that they should not be generally recommended, although for some particular indications they could. And I think the hyaluronan binding assay, the big paper by Miller, very large study, which showed a miscarriage rate lower in the PIXI arm, is an interesting one. And ESHRE didn't mention the miscarriage rate. They talked about the lack of evidence for improved live birth. So indications are really, really important. And it does state both on the HFEA website and the ESHRE draft guidelines that some add-ons may benefit some patients. So these examples I thought were interesting and just sum up how particular indications can benefit from particular add-ons. So we have the artificial oocyte activation. There's some evidence that that can benefit patients who've had previous low fertilization or globosospermia. IVM, in vitro maturation, for some polycystic ovary syndrome patients. Sperm activation, artificial activation, some patients with astenosospermia. So this is all from the ESHRE draft guideline. Steroids, generally not indicated, but for patients with autoimmune conditions, may be. Similarly with freezall, indicated only for OHSS patients. And there is suggestion that there may be psychological benefit for patients, for some patients, with intravaginal or intrauterine culture devices. So it's a bit of a minefield, and but I think that the way forward will be to map out the add-ons by indication, and that's what we've tried to do in our own hands. And one of our indications, interestingly, so we have the obvious, so unexplained infertility, advanced maternal age. We have poor fertilization previously, poor embryo quality previously. But one of our indications is patient request, because some patients, they've done their own homework. They may be super scientists. They may have been involved in some of the research. They, for whatever reason, they want a particular add-on. So providing it's safe, if they want it and they've done their research, and providing the clinic offers it and has competence and confidence in offering it, then I personally think that's okay. So just to summarize, do they work? Some work, some don't work. But the most important thing, the cat's knocking at the door, that patients deserve clear and honest information. I don't think anybody would argue with that. And it's important that they should make informed choices. Gone are the days where patients walk into the consultation room and said, just tell me what to do. They've done their homework generally, and of course they want advice, they want professional opinion, but they need information and they need to make the decisions based on their own requirements. So add-ons all need to be scrutinised, absolutely, but primarily on patient indication and also on the benefit, the cost and the safety, all probably equally important. And I've mentioned that I think it's really essential that to offer technical add-ons, the laboratory or the clinic need to have competency in offering those techniques. So I remember with mitochondrial, pronuclear transfer for mitochondrial disease, many years ago, we looked at that, but it's completely specific. It needs a particular skill set. It's not commonly required. So let's let the specialists do that. That's not something that should be offered broadly by every clinic who would be doing 1 or 2 procedures a year, maybe less. So just to finalise then, so there are great challenges in navigating all of this information in the literature, and we need to support our patients to do that. So we need to do the legwork, but accept that some of them may also have done their own research. And randomised control trials, fabulous, but they're not everything. There are many other ways that we can demonstrate evidence, and we need to look a bit wider than the RCT, at least in my opinion. And thank you very much for your time.
Thank you very much, Alison. That was really great. I'm delighted to hear you make those points, and I think in many ways we're singing off the same hymn sheet, although of course I would make the point that our test is not an add-on from the HFEA's point of view. It's just simply add-ons to treatment, but I take your point entirely. I think that the issue of patient choice is enormously important, and I agree with you entirely that the only endpoint being live birth is possibly a little bit narrow and a little bit strict. I mean, in the HAB Select study, which you mentioned, which I was very deeply involved in, we found the effect on miscarriage. The people were, particularly older women, were having less miscarriages, and yet it is still not an add-on which is acceptable to the HFEA and presumably to ESHRE as well, because they are only interested in primary outcomes. The reason why people want so many add-ons is because live birth rates are so low and they want to improve their success rates. What would you say about that? Why do you think our success rates have remained at sort of 30% throughout the history of IVF?
Well, I think they're improving gradually, and I think we're getting to the point where we're looking for marginal gains. We just need to fine tune. We've certainly in our clinic group seen incremental increases over time, some of them very small, a couple of percentage points, but as long as we keep heading in that direction, and there are just so many factors. I think that's the challenge in our field, isn't it? It's I'm confident that we get there, we will get there, and we are seeing these marginal gains. We're looking at big data now. We're not just, it's not all about the sperm or the egg or the embryo. We're looking at the the maternal environment much more. So, but I'm always the optimist. So, but I think we are heading in the right direction, and I don't think we're plateaued.
Yeah. Okay. Although there was a paper that came out recently that showed, worldwide we were plateauing, and it was talking about the commodification of ART, but maybe that's a question for another day. Even the fact that ESHRE looked at 27 add-ons and only recommended 3, I assume that was just on the very strict viewpoint of did they improve live births or not? Wasn't that the case? Yes,
again, they've looked at it in a very generalized way, but then gone on to say for specific indications there may be benefits. So it's just about teasing it out. But yeah, that's why if they were applicable to everyone, then they wouldn't be add-ons, they would be routine. So I suppose that makes sense, but we need to be able to look at them by indication. I think that's really important.
Yeah, okay. Gulam has a question for you here. RCTs so far are non-supportive of time lapse. What more can you say to support your position?
Well, do I wish we'd done a randomized controlled trial 8 years ago? Probably yes, but it was very clear once we'd started using it that we were seeing improvements, and we have published. We've not published randomized controlled trials, but we've published the evolution of our algorithms, and you can see, I think that chart shows beautifully that we can predict which embryos are going to result in a live birth. We can rank embryos based on their chance of achieving a live birth. So all of the randomized controlled trials that have taken place relating to time-lapse imaging are really different to each other. What we should have done, but it's too late now, but the ship's sailed for us. I would have liked to now, looking back, but we could have set up a trial all doing the same thing, the same culture medium, the same selection method or simple algorithm, and then compared against controls. But I would feel like it was an almighty retrograde step now and actually doing patients a disservice again if we suddenly reverted and introduced a randomized controlled trial. Our algorithms are moving at a pace, so we're on our 6th iteration. What we need to do, and what we are doing, is testing our algorithms on independent data just to see if we can rank from someone else's data, because it may be that they're not transferable, which would be very disappointing. But if they're not transferable, they should be calibratable. We know that algorithms, particularly with AI, you can calibrate them so you can make them applicable, or you can retrain them. But we've learned a lot, and I strongly believe patients are benefiting from what we've learned and how we can apply, not just in a time-lapse setting, but also to standard incubation. So like the fertilization example, we can make sure we don't miss fertilization, or we can optimize the time that we check fertilization. We can start to, well, we've moved to a please do not disturb culture in our standard incubators, because we realized from the learnings from time lapse that the chance of us seeing what we need to see in order to make an informed decision on an embryo from standard culture is so small that let's not take the risk of disturbing them just to get some information that we're not going to be able to use or apply. So it's having benefits for all patients. So yeah, I'm a fan.
Yeah, no, I think you're absolutely right, and I think you've answered the question very, very well. But one of the problems, I think, with any randomized controlled trial, particularly in the private sector, where patients are being given choice, is you can't randomly choose that patients who are paying for the treatment and are aware that that this may have a benefit. You can't then put them into the placebo. So I mean, I've always had this problem with our test of DNA. Yes, I would absolutely love to do a randomized controlled trial and see if people, do better with IVF or ICSI. But there's so much data out there, and people who want to have a DNA test are going to have a DNA test because they believe it's going to help guide the treatment. So they will not be willing to say, okay, doctor, just do your paternalistic thing and tell me which group I'm going to go into. Those days have long gone.
Yeah, ship sailed.
Yeah, I think it has. Can you talk about the public and private sector? We were talking about this a little bit before we came on air. In the private sector, you can have add-ons dependent on your clinic and dependent on your doctor. In the NHS, very often add-ons are not either offered or the patients are not informed as to their existence. I'm inclined to think that that's discriminatory against patients who are having publicly funded treatment. Would you like to comment on that as to what you think?
Yeah, no, I completely agree. And it's been very difficult because we want to promote these services to the patients that it's applicable for, but we've got to be careful because we don't want to offend the NHS funded patients who can't access these amazing treatments. Mm-hmm. So until recently, it has been really difficult to navigate because some NHS treatments in some postcode areas, they could add on officially, and in others it was discouraged or it was said it wasn't appropriate and it's not to happen. So that, when we've got a network of clinics, has been quite challenging because it's certainly not fair. So no, now we've taken the decision to offer add-ons that are appropriate to NHS patients as well, so they can access them finally. So I'm pleased. I think that's a really big step forward.
Yeah, I think that's great. Jonathan Ramsey has both a compliment, thank you, and thank you particularly for highlighting the conflict between an RCT and informed patients' consents. And he also wants to know, and I wonder if you could add to what you've already said, how best to design a large case study.
Yeah, well, it's sort of without, in my experience, these large case studies, they can happen by default. So with these algorithms, for example, we develop a new time-lapse algorithm based on large historical data. We hold back some data in order to validate or to test the effectiveness. And then once that's satisfactory, then we move forward. So we start then from time 0. Now all patients coming through will get this new treatment, this new algorithm, and there's the case series. So for the next 1,000 patients, it's routine, but we're gathering data all the time and analysing on a regular basis. So that's how we've tended to approach it, rather than design it prospectively, which would be the ideal, but it is still prospective use of the algorithm in this example. So we're still accumulating large data, and I accept that that's difficult for people to do if they're in a small standalone clinic where they may not have the resource or the expertise. But when you're in a large network and you're working in the same way, then it's really quite easy to gather data quickly. All the laboratories work in the same systems, the same pipettes, culture medium, oil, dishes. So to introduce something like a new algorithm and then reflect after the first 1,000 cases may only take 3 or 4 months to do. So we're in a very privileged position, and we need to publish more. I'm conscious of that.
Great. Well, we haven't got any more questions from the floor, so I'm going to take the liberty of asking you another question, or asking you to comment on what I think. In Fertility 2023, we had a debate, as we always do, at the end of the conference. And the debate this year was, this House believes that women over 42 should not be offered ART with their own eggs. Now, we had 2 extremely good debaters, and the person who was debating for the motion and saying we shouldn't offer people ART with their own eggs, although he had wonderful evidence, the floor was very much against his point of view, simply because they felt that patient choice was paramount. So what would you do in your clinic if patients came along asking for some of the slightly more dubious add-ons, which you felt personally, well, we're not talking safety. I think there are very few of these add-ons that aren't safe, but just from the point of view that there was very little evidence that it would be successful, but the patient really wanted it. How would you approach that? What would you say to them?
Well, we wouldn't, it depends how dubious, we wouldn't offer a dubious add-on. we do have patients coming asking for really novel add-ons that maybe they're on our radar, but we're not using them routinely. We haven't really evaluated them fully or made a decision on them. And in those cases, we'd say, we don't offer that. We wouldn't just get it out of the cupboard, a sample, and use it, no chance. But for most indications, we have a really broad toolbox. So we'd tell them what we do offer for their indication. And it might catalyze us to look into it a bit more detail. But I'd say, generally speaking, we keep up, and we have our own internal panel. So we'll analyze and assess whether or not we've actually ranked them. We've ranked all add-ons that we can think of, from 1 to 4, and 4 is, we don't think it's safe. We're not going to offer it under any circumstances. So but patients, they can be very demanding, and so it's about giving them the information and supporting their decision making, and maybe offering alternatives if we have effective alternatives, but nothing dubious.
Well, that's a great answer. I do have one more question for you. Sorry, I thought you thought you were at the end, but there's one here. It says, do you know much about Max versus Pixie or microfluid chips like Zymot? Well,
Max, I've had very, very little experience with. It must be over a decade ago I had a look, and it was so cost prohibitive that we didn't take it any further. So not much experience more than that. With Zymot, I like it. I think it's relatively early days. The literature's really interesting. Again, we've got some mixed reports of whether it's effective or not. Is it a horizontal swim up, or is it microfluidics? So a bit of a question over that. The lab absolutely love it. Workflow is great. It reduces consumables, so it's nice and sustainable, arguably. You can offset some of the costs. It's not the cheapest device, but you can offset some of the costs because you're using less tubes, maybe less RFID tags if you're using a particular witnessing system. So I think it's very promising, and I expect there'll be more alternatives to choose between. And what was the other one? Pixie. I like the theory. Often, all of these add-ons are based on theory and science and biology, and I very much like the biology and the theories behind Pixie. We don't offer it routinely. It's not highly demanded by patients. The literature, as we've said, is a little bit mixed, but in terms of reducing miscarriage rate, so it's about identifying the patients that may benefit from it and getting it to the right patients, and not using it broad brush for everybody who may not benefit, because it will increase the cost presumably a little bit.
Okay, well, that's the last question. So thank you so much, Alison, for giving up your time. I know you're crazily busy, and we really do appreciate it. And tonight has been very informative and very interesting. And I would just like to say, on behalf of everybody who's listening, thank you very much.
Thank you. It's been lovely. Thank you.
Okay, over to Lindsay. I think you're going to tell us about the next webinar.
I am indeed. Thank you all for joining us this evening, and we hope you can join us for our next event in the series. That will be taking place on the 4th of April, when Laura Carter-Penman, the Deputy Director of Fertility and Women's Health at Peppy Health, will be joining us to discuss how Peppy is helping empower men to be healthy. Registration for this event will be open tomorrow, so keep an eye out for the emailed link. That leaves me just to thank you all again for joining us this evening. Please do not hesitate to reach out if you have any queries, and we look forward to seeing you at the next webinar on the 4th of April. Enjoy the rest of your evening.